introduction here. Hello, everybody, and thank you for joining us. I'm your host, Megan Dotson. I appreciate the time you took today to rejoin us. This is a redo from last week. The training series that we're giving you today is brought to you by the National American Indian and Alaska Native Mental Health Technology Transfer Center, and we're part of the MHTTC network that's located here in Iowa City, Iowa. So the National American Indian and Alaska Native Mental Health Technology Transfer Center is supported by a grant from CSAT and SAMHSA. This project is the content developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native MHTTC. In the next couple of days, we will send out a follow-up email to everyone who attended, which includes a link to the recording, the handouts of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs if you desire. We are currently waiving any fees for CEUs during the pandemic, and when we send out our follow-up email, it will contain instructions on ordering your certificate. You will be redirected to our GIPRA survey evaluation at the end of this session. This survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion. Would greatly appreciate the time and sharing your thoughts with us. You will be muted for the duration of this webinar. You can use the chat feature to share when you would like, if you want to say where you're from and make comments about the presentation. We will hold a Q&A box at the end for our presenter and ask that we keep the questions held off until the end of the presentation. And we're very excited to have Avis Garcia with us today. She's an enrolled member of the Northern Arapaho Nation and affiliated with the Eastern Shoshone Tribe of Wyoming. And she earned a doctorate in counselor education and supervision at the University of Wyoming, and is also a licensed professional counselor and licensed addictions therapist. For 19 years, she has been a mental health provider in the treatment of Native American youth and families. She is also an advocate of education in Indian country, a resource provider for promoting cultural enhancement of evidence-based practices and practice-based evidence of treatment approaches for Native American children and their families exposed to trauma. Avis Garcia has more than 19 years of experience and is knowledgeable about the concerns of implementation and adaptation of evidence-based practices being introduced into Indian country. Avis is currently employed as an executive director of a nonprofit substance abuse treatment center in Cheyenne, Wyoming. So with that, we are thankful that she is here today to provide us with some knowledge that many of us do not have. Some of us do. And Avis, I will turn it over to you. Thank you so much.
Thank you. Thank you to everyone who was understanding and returned if you were logged on last week. My computer wanted me to update my Zoom, and I couldn't do it right in the middle of the session. So I think we got that all worked out this morning. My name is Avis Garcia, and like they said, I am Northern Arapaho and Eastern Shoshone. My mother was Arapaho and my father was Shoshone. I was raised on the Wind River Reservation, so it's a little ways to get to the reservation from where I'm at right now. And I have been working in the substance abuse field for several years now. And in my very first year of actually practicing as a counselor, I worked in residential treatment for about 2 years in an agency called Southwest Counseling in Rock Springs, Wyoming. What I noticed, majority of the participants at that time were mostly Caucasian, and maybe we would have one Native every now and then, and they would usually come from our reservation. And what I noticed was people are not willing to just come right out and tell you that they've been through some trauma. And I noticed for all the participants, regardless of race, they waited till almost their last day to graduate treatment and they would drop a bomb. Since then, I have taken an interest in helping people with trauma because it just seems to coincide along with addictions. So to begin with, trauma-informed care is an organizational structure and treatment framework that involves understanding, recognizing, and responding to the effects of all types of trauma. Trauma-informed care also emphasizes physical, psychological, and emotional safety for both consumers and providers, and helps survivors rebuild a sense of control and empowerment. Child traumatic stress, the physical and emotional response a child has to events that pose a threat to the child or someone important to them. When a child experiences trauma, the child may be unable to cope, have feelings of terror and powerlessness, and experience physiological arousal that they cannot control. Most children don't have the vocabulary to even explain what they might be experiencing. Child traumatic stress. A traumatic event can affect the way children view themselves, others, and the world around them. It can impact how they view their future. A child who has experienced trauma may not be able to trust others, may not feel safe, and may have difficulty handling life's changes. Most children who become involved in the child welfare system have likely had multiple exposures to trauma. And I'm trying to think of an example. I tend to tell a lot of stories about work experience when I do these presentations. And I would do some work at our youth shelter on the reservation, and that would be where social services usually brought children when they were displaced from their home because of abuse, or maybe they were being delinquent and running away from their family, so they were placed there. And as I worked with some of these kids, they did experience a lot of trauma, but they weren't even aware of it, you know. And even at that time, there wasn't much concern about, you know, this person is having some trauma and I don't know how to help them. I would say in the last decade, this has become more popular in the counseling and helping professions of being able to provide trauma-informed care to all people. So that was why I was asked if I would do a presentation on some trauma care. And I'm also a certified trauma specialist. Some children are exposed to family violence and sexual abuse and foster care. Sadly, I've encountered some children who were sexually abused in foster care. Substance abuse can also include physical abuse and removal of the primary caregiver. And as I was talking about the youth that I was working with at that time, a methamphetamine bust occurred on our reservation, and several families went to prison. And all the children had nowhere to go because it even affected the grandparents. So they lost all type of primary care that they should have had. As a universal precaution, the prevalence of trauma is so high that child welfare workers could assume that everyone they serve has a trauma history. Diagnosis. Everybody wants to know. A lot of the diagnoses tend to fall in line with the criteria for PTSD. But the DSM-V defines it as provides clinical descriptions, diagnostic guidelines, and codes for all mental and behavioral disorders commonly encountered in clinical psychiatry and mental health treatment. A comorbid diagnosis is the co-occurrence of one or more diseases or disorders in an individual. In mental health, an example would be schizophrenia and alcohol or drug abuse. Quite often, I see a lot of PTSD and alcoholism or drug abuse. The impact of trauma. The immediate emotional reaction to trauma can include numbness, detachment, anxiety or severe fear, guilt, which can include survivor guilt, exhilaration as a result of surviving, and anger and sadness. So there's a lot of emotions going on. Immediate emotional reactions continued is helplessness, feeling unreal, depersonalization, feeling as if you're watching yourself, disorientation, feeling out of control, denial, constriction of feelings, and feeling overwhelmed. Some delayed emotional reactions, and not everyone experiences trauma immediately after the trauma. People tend to, there are some people that tend to compartmentalize, or in their mind they put it somewhere and put it away and just don't want to think about it. So it could come back years later and they can start having memories of the trauma that they went through. So some delayed emotional reactions might include irritability or hostility, depression, mood swings, instability, anxiety, phobia, fear of trauma. They'll be afraid that it's going to happen again, and grief reactions of maybe they lost something while they're from their trauma. So trauma-related thoughts or feelings, and the triggers can be people, places, conversations, activities, objects, or situations. I've even had some people say certain smells can trigger that for them as well. Delayed emotional reaction also includes shame. That is quite common with sexual abuse survivors. Feelings of fragility or vulnerability, emotional detachment from anything that requires emotional reactions, such as significant and or family relationships, conversations about themselves, discussion of traumatic events or reactions to them. So it's really important to not leave someone who is experiencing trauma alone. They should always have access to some physical person so that they don't have any more trauma reaction. Some immediate physical reactions includes nausea or gastrointestinal distress, sweating or shivering, faintness, muscle tremors, uncontrollable shaking, elevated heartbeat, respiration and blood pressure, extreme fatigue or exhaustion, greater startle responses, and depersonalization. More delayed reactions includes sleep disturbances, nightmares. Maybe they start remembering that trauma that they tucked away. There's somatization, increased focus on and worry about body aches and pains, appetite and digestive changes, lowered resistance to colds and infection, persistent fatigue, elevated cortisol levels, hyperarousal, long-term health effects, including heart, liver, autoimmune, and chronic obstructive pulmonary disease. And quite often, I believe that a lot of the people who are experiencing trauma, even if it's delayed or acute, they're more open and willing to go to a doctor and tell them they're having these physical symptoms versus what's really triggering them to feel that way. And they might not even be aware of it themselves. So sometimes it's letting them know that the reactions they're having, you might want to screen them or probe them to get some information about possible trauma. Immediate cognitive reactions to trauma. They may have difficulty concentrating, ruminating or racing thoughts, replaying the traumatic event over and over again, distortion of time and space. Traumatic event may be perceived as if it was happening in slow motion, or a few seconds can be perceived as minutes. They can have memory problems, not being able to recall aspects of trauma, and a strong identification with victims. Delayed cognitive trauma. Intrusive memories are flashbacks, which is quite common with combat veterans. Reactivation of previous traumatic events, self-blame, preoccupation with event, difficulty making decisions, having magical thinking, believing that certain behaviors, including avoidant behavior, will protect them against future trauma. Belief that feelings or memories are dangerous, and generalization of triggers. A person who experiences a home invasion during the daytime may avoid being alone during the day, and some may have suicidal thinking. They may also have a startled reaction, restlessness, sleep and appetite disturbances, difficulty expressing themselves, be argumentative, increase their use of substances, withdrawal and apathy, and avoidant behaviors. So from a personal viewpoint, I feel that our participants that come for substance abuse treatment, a lot of them have trauma. I would say 90% of them have been through some sort of trauma. So it's real important that we screen for that, and so that they don't feel shamed for using alcohol or drugs, because that was what they found helped them to cope with what they were experiencing. Delayed behavioral reactions would be an avoidance of event reminders. Maybe it's the anniversary of the car accident or the house fire. Social relationship disturbances, decreased activity level, engagement in high-risk behaviors, increased use of alcohol and drugs, and withdrawal. Immediate reactions to trauma could be intense use of prayer, restoration of faith and goodness of others, receiving help from others, loss of self-efficacy, despair about humanity, particularly if the event was intentional, and immediate disruption of life assumptions, fairness, safety, goodness, and predictability of life. And I've also seen the flip side of the intense use of prayer to no longer believing in whatever religion they practice. Some more delayed reactions would be questioning. Why me? Increased cynicism or disillusionment, increased self-confidence. Some people think, hey, I gained something from this. If I can survive this, I can survive anything. They may have a loss of purpose, or like I said, renewed faith, or lose faith, hopelessness, reestablishing priorities, redefining the meaning and importance of their life, reworking life's assumptions to accommodate the trauma, such as taking a self-defense class to reestablish a sense of safety. Some statistics. Children who experience or witness violence, about 5 million children witness domestic violence each year in the United States. 40 million adult Americans grew up living with domestic violence. And children from homes with violence are much more likely to experience significant psychological problems, including short and long term. So for those of you that are working with children or that are in the schools and somebody's noticing some behavior changes, that would be something to take a closer look at. 1 in 15 children are exposed to intimate partner violence each year, and 90% of these children are eyewitnesses to this violence. And I think when I was doing the domestic violence presentations, I had gone to my daughter's house because she's going to school at the university, and she got our newspaper from the reservation. And as I looked at that newspaper, I felt really bad after I finished reading it, because the front page had a domestic violence case on the front page, and then inside the newspaper were 2 more. And a lot of these people were quite young. And I was just really thinking to myself, it's such a shame that, there's children that see that. Children who've experienced domestic violence often meet diagnostic criteria for PTSD. The effects on their brain are similar to those experienced by combat veterans. Domestic violence in childhood is directly correlated with difficulties in learning, having a lower IQ score, deficiencies in visual motor skills, and problems with attention and memory. So this does a lot of damage that people don't realize kids are being exposed to. Living with domestic violence significantly alters a child's DNA, aging them prematurely 7 to 10 years. Children in homes with violence are physically abused or seriously neglected at a rate of 1,500% higher than the national average. Those who grow up with domestic violence are 6 times more likely to commit suicide and 50% more likely to abuse drugs and alcohol. If a child grows up with domestic violence, they are 74% more likely to commit a violent crime against someone else. So a lot of times they don't even realize that they're actually teaching their child that this is how you handle your marital problems or anger or disagreements is, with physical violence. And that's not always the best thing for children to witness. Children of domestic violence are 3 times more likely to repeat the cycle in adulthood, as growing up with domestic violence is the most significant predictor of whether or not someone will be engaged in domestic violence later in life. How children respond to the domestic violence. Children's immediate reactions to domestic violence can include having generalized anxiety, sleeplessness, and having nightmares. They can have difficulty concentrating, have high activity levels, increased aggression, increased anxiety about being separated from a parent, or maybe their parent didn't survive the trauma and they're really traumatized from losing their parent, or their parent went to jail. Intense worry about their safety or the safety of a parent. That's a lot for a young child to be seeing. How many children witness the abuse of their mothers? 3 to 4 million children between the ages of 3 to 17, are at risk of exposure each year. The US government statistics say that 95% of domestic violence cases involve women victims of male partners. And I grew up with domestic violence in my home. I saw my mother go through domestic violence with my own father. And then when she started to drink really bad, she tended to get involved with these men who all abused her physically. But by that time, I had already left the home and went to my grandparents' house to go stay with my grandparents. And I felt safer there. And, grandma never drank and she gave me a safe home. So I just decided I was going to stay there. And my mom never got me. What witnessing violence can mean is seeing actual incidents of physical or sexual abuse. It can mean hearing threats or fighting noises from another room. Children may also observe the aftermath of physical abuse, such as blood, bruises, tears, torn clothing, and broken items. Finally, children may be aware of the tension in the home, such as their mother's fearfulness when the abuser's car pulls into the driveway. Children from violent homes have a higher risk of alcohol and drug abuse, post-traumatic stress disorder, and juvenile delinquency. Witnessing domestic violence is the single best predictor of juvenile delinquency and adult criminality. It is also the #1 reason that children run away. Six principles to the trauma-informed approach include safety. You want to help this individual feel safe and have a safe environment. You want to be transparent with them and be trustworthy. If you tell them you're going to do something, make sure that you follow through with that. Peer support. A lot of mental health agencies are using peer support not just for drug and alcohol, they're also using it for suicide, using it for mental health problems so that they can work with others to get peer support. Collaboration and mutuality. So you can't just say you're going to do this and that. You need to be able to give them a choice and let them know that you're there to work with them, alongside of them, and not just have a cookie cutter approach. You want to empower them with voice and choice. You want to give them some hope that they can get through whatever situation that they are traumatized by. And then also cultural, historical, and gender issues. So there's a lot plays into this. And this is just the first of a series of 5 sessions that I'm going to be presenting. So I'll be telling you a lot more of some treatment approaches. And trauma-specific assessments. A lot of people really want to do some assessments so that they have documentations that shows what they might be experiencing and just how traumatized that person is. Here's one called SCARED. It's a child screen for anxiety-related disorders. So that's for children. It's a 41-item self-administered scale that aids in the diagnosis of panic disorder, significant somatic symptoms, generalized anxiety, separation anxiety, social anxiety, and significant school avoidance. The SCARED interpretation has these five areas that it assesses, which includes the panic disorder and significant somatic symptoms, and generalized anxiety, separation anxiety, and social anxiety, and avoiding school. So any score of 25 or higher will indicate the presence of anxiety disorder. There is a revised Children's Manifest Anxiety Scale, the 2nd edition. This one is a 49-item self-report instrument designed to assess the level and nature of anxiety in children ages 6 to 19 years old. This yields scores for 6 scales. The scores measure defensiveness, inconsistent responding. The remaining 4 scores include a total anxiety score, scores for 3 anxiety-related skills, which includes physiological anxiety, worry, and social anxiety. Additionally, it's content-based of 10 items that ask specifically about performance anxiety is delineated so that clinicians can focus on this particular topic in follow-up evaluation and activities in appropriate cases. This one requires some qualifications to administer. To administer, score, and interpret, individuals should have or be supervised by someone who has formal coursework in psychological tests and measurements, understand the basic psychometrics that underlie test use and development, and have supervised experience administering and interpreting clinical tests. The Child Behavior Checklist, age-related reports, from 1.5 to 5 years old, 6 to 18, and 11 to 18. The Child Behavior Checklist, The first pages of the checklist records demographic information, rating of positive behaviors, academic functioning for the school-aged version only, and social competence. The last 2 pages list common behavior problems, each listed as a brief statement about the child's behavior. And I believe I've included this as an attachment to this presentation because this behavior checklist can be used by anyone. The main scoring is based on statistical groupings of sets of behaviors that typically occur together. The original scale used principal component analysis to group items, and more recent research used confirmatory factor analysis to test the structure. So this has been well tested. The child behavior checklist also uses a donative sample to create standard scores. These compare the raw score to what would be typical compared to responses for youths of the same gender and the similar age. Now for adult assessment tools. There is a modified mini screen, a self-report measure that rapidly assesses the present mood, anxiety, and psychotic spectrum disorders. The mental health screening form number 3, a self-report measure that covers a range of disorders. And I think I've attached this one as an attachment to this one. This mental health screening form is one that I use at my agency. It is required for us by CARF, which is an international accrediting agency, which says, you know, you guys provide like top of the line substance abuse services. And this is what we use with everyone that we admit to the program, is we use that mental health screening form. CAGE is just a short screening form for drug and alcohol, and it can also be for looking at some trauma. It would help you be able to be like, you know, what could be causing you to drink or use drugs more? Is it, you know, are you okay? The adult assessment tools continued. There is a simple screening instrument for alcohol and drugs, and this is the CAGE aid. Beck inventories, assessment tools for depression and anxiety for individuals aged 13 and up. And you can download the Beck and the depression and anxiety assessments online. Those are easily accessible. The PTSD checklist checks for symptoms resulting from a traumatic event. And I believe there's probably 2 more sections in my intake packet at the agency where we're screening for trauma and suicide more than once. Social anxiety scale is a self-report measure where respondents rate their distress about specific social interactions. The Brief Trauma Questionnaire is a 10-item self-report questionnaire derived from the brief trauma interview, can be used to determine whether an individual has had an event that meets the A criterion, or to determine the different types of criterion A events an individual has experienced. And this one is also easily accessible online for anyone that would like to use it. The mental status exam is always part of the intake assessment in the counseling profession. It's a very important part of the clinical assessment. It's a structured way to observe and describe a patient's psychological functioning at a given point in time under the domains of their appearance, their attitude, their behavior, their mood, affect, speech, thought process, thought content, perception, cognition, insight, and judgment. The purpose is to obtain a comprehensive cross-sectional description of the patient's mental state. The National Institute for Trauma and Loss in Children's Trauma Assessment looks at 3 specific areas. That is the re-experiencing of the traumatic event, avoidance of stimuli associated with the traumatic event. Maybe they don't want to go home because they're afraid domestic violence or maybe sexual abuse is happening and they just don't want to go there. Symptoms of increased arousal due to a traumatic event. This also has a parent questionnaire and has child and adolescent versions. Intake, assessment, and treatment plans. The intake includes the basic demographic information. This is where you gather information about the client, ask them about any past mental health treatment diagnoses, family history, and current or past social problems with work, school, or relationships. And it's also a psychosocial evaluation used to determine past and current substance abuse problems, as well as any psychiatric drugs that the client has used in the past or is currently using. You need to explain your limits of confidentiality. Be prepared to deal with crisis situations in an intake appointment. Someone may be disclosing that they were physically attacked, sexually assaulted. You need to let them know that if there's anything shared about someone being hurt, either themselves or someone else, that as a mandated reporter, that your limits of confidentiality only go so far, but that is for the best interest of anyone involved, even if they're the perpetrator. Have a crisis intervention plan in place if you are not working for an organization that already has one. You can use a safety plan, and a lot of those are available online. I use them for relapse prevention plans as well. But this is so that they have a plan of action if this is a domestic violence situation and they're going back home, and how they're going to keep themselves safe and their children safe. And just having that plan makes them feel like they have some control. You want to ask them, what is the reason for the referral? I always ask them, what brings you here today? How can I help you? You want to look at their current symptoms and behaviors. You want the history of the problem. How long has this been going on? Has this happened before? Impairments in life functioning. So maybe they're having trouble doing their job or just taking care of themselves. So you need to be looking for co-occurring symptoms that could be going on at the same time. Psychological and psychiatric history. You want to know if they've ever been diagnosed, and most are pretty open, and how often they've received treatment, or are they about to receive treatment. You want to assess their current risk and safety concerns, current substance use and substance use history. You want some information on their family background. You want to check for socioeconomic level, the parents' occupations, parents' marital status, cultural background, emotional and medical history, and their family relationships. A lot of people that deal with trauma come from homes where there's an absent parent, and so maybe they don't have contact with their father anymore or their mother anymore. You want to get some of their personal history. You want to know how, what they know about their infancy. What did their parents disclose? Were there any complications when they were born? Did they reach those developmental milestones when they should? The early and middle childhood, again, looking at those milestones in their life, if they're achieving what they should be at their age level. Adolescence, early and middle adulthood, and late adulthood. So kind of traveling back in time to see if perhaps there might be a pattern. Again, you also assess their mental status. Miscellaneous self-concept, like and dislike, their happiest and saddest memory and fears. If they're having any dreams, are they having recurring dreams? and dreams that the client has had where they're being hurt. Summary and clinical impression. So when you're all done getting all of that information, you need to summarize everything and do your case conceptualization for your clinical impression, which leads you to give the diagnosis and your recommendations for treatment. Some behavioral observations you want to be aware of are eye contact. How much eye contact are they giving you? Grooming and hygiene, their orientation, do they know what day it is? Motor activity, their speech, their interactional style, their intellectual functioning, their memory, their mood and affect. Are there any perceptual disturbances, any behavioral disturbances? And these should be evaluated at every visit. It's important to do an ongoing assessment and change the treatment plan as needed. Then from there, you'll want to develop some treatment goals with the client. So you would want to ask them, what would they like to focus on obtaining some help for? One example is a major depressive disorder. They may want to reduce their symptoms of the depression or learn some coping skills for when their depression is at its worst state. If a client has symptoms, think of goals for each symptom. For example, if they're having insomnia, we need to help them with some sleep hygiene. Some depressed mood, have they gained weight recently? Or each of these could have separate goals, but you don't want to have too many. 1 or 2 is usually good to start out with. You want to ask, what is one goal they have for therapy? And what is it they would like to be different in their life? What steps can you take to make this happen? Offer some suggestions and ideas if they get stuck. Ask scaling questions. On a scale of 0 to 10, how far the clients feel they have come to reaching their goals. So using that for their goals is a real helpful measure, and some of them may go ahead 2 steps and back 1 step, so it won't be a smooth progression. Making your concrete goals for treatment. You want to be specific. You want to set measurable goals, just like we said with the scale, making sure they are achievable. Set realistic goals and time-limited goals. And most treatment plans run for a period of 90 days. You'll also want to discuss what interventions you will be using so that they know what's going to happen next. And you want to review and improve the treatment plan as needed. Progress notes. You want to record the content of the therapy, such as Tammy admitted to feeling overwhelmed and anxious about an event when completing the smallest project. She stated she becomes easily frustrated when completing tasks. The client said, "When will this feeling end?" For a therapeutic intervention, the main intervention used might be cognitive behavioral therapy, which is the most common. Mindfulness and solution-focused therapy can also be used. Progress notes on the mental status. If you're not using a checklist, know if the client is irritable, distracted, their communication level, how they are groomed, and if there is anxiety or delusions. Bizarre behaviors or other indicators of psychotic process should be noted. Identify if associations are intact and age appropriate, and know if short and long-term memory are intact. Progress notes, instructions, recommendations, and plans. Again, set short and long-term goals. So if you take your main long-term goal, you may be able to break that down into 2 steps that goes along with your main goal. Note start and stop times, and the diagnosis and homework given and completed. Identifying specific behavior patterns. A child who appears oppositional or aggressive may be reacting to anxiety he can't articulate. We might see outbursts in school. The child may go ballistic, throwing things, kicking and hitting staff. Some people can't tolerate criticism. Fear and embarrassment took over. In younger children, we might see freezing or clinging behavior. However, we may see tantrums and complete meltdowns. While some children and adolescents act out, others retreat within themselves. So what we want to do is identify specific behavior patterns. Take me through your typical day, what happens during the day, or maybe when this situation occurred, when did they start having nightmares, or when did they start feeling intense anxiety? Because like I said, they may not have those reactions immediately. They can be delayed as well. So we want to interrupt that pattern if it's not helping the person, based on notion that behaviors, including negative ones, may be automatic reactions to events that are stressful. Pattern interruption attempts to alter part of the reaction pattern, making behaviors more conscious and in turn more controlled by the person. Pattern interruption steps: discover the sequence of behaviors that surrounds the problem behavior. If a child blurts out answers and ignoring hasn't worked, you might want to ask them to move to a blurting desk. So maybe in the classroom, you have a desk designated for someone to go do their blurting. For adult clients, for example, if a mother habitually nags her husband, have her write her nags on a paper and decide if they are worth giving to her husband. If they are, she can hand those to him on paper and not have a verbal conflict. Patient characteristics. For older children and adults who want to change their behavior, pattern interruption helps provide a shortcut to identifying and ending the behavior. For younger children, it may be easier to work on the parent's reaction. This technique requires a good level of rapport. Principle and assumptions of pattern interruptions. The approach must make sense to the client and family members involved in the treatment. A reframe is often necessary. Indicators and measurements of success of pattern interruption. When the client changes one small behavior and there has been success, they'll notice a change in other larger areas. Client and our family feels hopeful and a sense of power that will be useful when tackling greater challenges they would like to make. Understanding trauma and its impact on clients, families, and caregivers. This is known as secondary traumatic stress. And for all of us that are in the helping profession that encounter these people, this is one thing we need to be mindful of as we work to support people. Is there any emotional duress that results when an individual hears about the firsthand experience of another person? Any symptoms that mimic those of PTSD? Individuals with secondary traumatic stress may find themselves re-experiencing their own personal trauma or notice an increase in arousal and or avoidance reactions related to the indirect trauma exposure. So some people may have had trauma in their lives, and I have had several, and I often think I must be one of those that has some resilient. And some people, this doesn't bother them that much, but we do need to be aware of anything that might be triggering us. So you want to consult with your supervisor or a colleague. Here's some types of disclosures. An indirect hint might be, my father wouldn't let my mom sleep last night. So you might want to ask more what was going on that he didn't allow her to sleep, or how has this happened before? Some more types of disclosures. A disguised disclosure could be, I know someone who's in a bad relationship. What would happen if a girl told her mother that her boyfriend was hurting her, but her mother did not believe her? Disclosures with strings attached. I have a problem, but if I tell you about it, you have to promise not to tell. Again, you have to remind them of those limits of confidentiality for people's safety. Integrated and interactive approaches to healing can include focused drawing and art, storytelling and games, parental support, mindfulness, the brain game, teach clients how their brain responds to trauma. Prolonged exposure therapy, which is commonly used for PTSD. It's appropriate for anyone who has experienced or witnessed a traumatic event, not necessary for those without a PTSD diagnosis. How the prolonged exposure therapy works, it's based on associative learning theory. When two things appear together, the brain learns to connect or associate them. Thinking about Pavlov's dog. When the trauma occurs, there are many things in the environment, smells, sights, sounds that the brain associates with the trauma. When we encounter those things outside of the trauma, the brain expects danger, which is our fight, flight, or freeze that we've had since the beginning of time, when we had to survive from dinosaurs and tigers, that can cause fear and anxiety. Based on behavior therapy and cognitive behavior therapy, it is characterized by re-experiencing the traumatic event through remembering it, engaging with, rather than avoiding reminders of the trauma, sometimes referred to as flooding. Compassion fatigue and the importance of self-care. Compassion fatigue, also known as secondary traumatic stress, requires you to be aware and take care of yourself. Remember, always care for yourself first. This is a little picture of my dog sleeping on the bed. He looks like he was stressed out and had a rough day. Some vicarious trauma can be intrusive thoughts and images related to the client's disclosures. Avoidant responses, physiological arousal, somatic complaints, distressing emotions, addictive or compulsive behaviors that may adversely affect their competence. So that's why it's very important to pay attention, because it can affect how you're providing services. Again, therapist burnout, you want to look for emotional exhaustion. Some of this is very hard to hear and to help people with, so it can take a lot of work. Depersonalization, loss of one's empathy, caring, and compassion, and a decreased sense of accomplishment. Some steps to self-care include these are just ideas: meditation, scrapbooking, yoga, your own therapy, journaling, baking, exercising, getting your hair done, painting, taking some time off, take a mental health day from work and just take some time to enjoy yourself doing what you like to do, reading, and putting the phone down. There is a self-care assessment, and I believe I also attached this to the handouts for this session. And one site that I find really helpful is called therapistaid.com. It has the self-care assessment. It has several worksheets that you can download, and it doesn't just cover trauma. It helps with a lot of other things that you can use for free to share with your clients. And that wraps up today's presentation. The rest of the slides are all references to books and sites that might be helpful to someone interested in doing a little more research. And like I said, this is just the beginning of the 5-part series. And so next month, in the second week on a Wednesday, I will be providing the next session. I think I'm going to be providing more treatment approaches the next go round. And I had a special request for trauma, trafficking, human trafficking. So that will be in the third one. My last presentation is going to be my native specific presentation on dealing with trauma and intergenerational trauma. So thank you guys for being here today. I hope you found something that was helpful for you today. I attached a few other things to this presentation that might be helpful to you all. And there is some stuff from SAMHSA. I think I attached their trauma book, which is 57. If you go onto their website, you can easily download it, but it should be attached to the handouts for this presentation. So I am open for any questions.
Avis, a lot of people wanted to say thank you to you, that they enjoyed this and that the presentation was very informative. Let's see. Certificates of attendance, you'll get an email with all the instructions in this, and the attachments Avis is referring to in the slides will all be within that email. That will come from Natasha Peterson. When you guys close out today, you'll be redirected to the really quick evaluation that we ask that you do. And then, like Avis said, our next series, number 2, will be March 10th at 12 p.m. Central. And this will run all the way to June. So if you guys have any questions, now is the time to ask those. We have about 2 minutes left. We'll give it a second, Avis, to see if anybody put something in the chat.
Okay.
I think you explained everything so well that there may not be any questions at this time. But a lot of people are really looking forward to your handouts and your slides so they can follow some of the guidance that you've shared today. So thank you for being so thorough with all of that.
Thank you. Thank you.
Lots of info to process. Yes. Can you tell Kathy the site where we can download the book?
That would be from SAMHSA.
Okay, that's what she
And
does. So good
yeah,
guess.
it's tip 57, and excellent free book.
Perfect. Thank you. Okay. Everyone is saying thank you. This is great information. So I think at this time we will conclude the webinar, and we will look forward to seeing Avis again back on March 10th at 12 p.m. Central. And we appreciate all of you guys attending today and letting us redo this from last week. So you can find this webinar on our website in the next couple of days. We'll be posting that on our YouTube page. So thank you, everyone. Thank you, Avis. Very, very informative presentation. And you guys all have a good rest of your day. Thanks so much.